Assalamu alaikum. Let's dive into a new topic called osteoporosis. Osteoporosis, also known as marble bone disease, it's a rare disorder of defective osteoclast function. So it's a rare disorder of defective osteoclast function, resulting in failure of the normal bone resorption. So decreased osteoclast function, decreased osteoclast function, resulting in failure of normal bone resorption. Okay, it results in dense, thick bone that are prone to fracture. There may be bone pain and neuropathies are common. Calcium, phosphate, and ALP, alkaline phosphatase, all the labs are normal. Stem cell transplant and interferon gamma have been used for treatment. So in osteoporosis, if you look at these MRI, you can see there is bone loss, cortical bone loss. So in osteoporosis, there is trabecular, spongy, and cortical bone loss mass despite normal bone mineralization and normal labs. So trabecular and cortical bone loss mass despite normal mineralization and lab value, most commonly due to increased bone resorption, increased osteoclastic activity related to decreased estrogen level. So postmenopausal women are at risk of having this osteoporosis and old age, cigarette smoking. These are the initial cause, and it can be secondary to drugs like steroids, alcohol, anticonvulsant, anticoagulant, thyroid replacement therapy, and other conditions like hyperparathyroidism, hyperthyroidism, hyperparathyroidism, hyperthyroidism, multiple myeloma, malabsorption syndromes, and anorexia, low bone mass, and prolonged microgravity exposure. So, prolonged microgravity exposure, like space travelers, are at risk of osteoporosis. So, space travelers are at risk of osteoporosis. Very, very, very unique cause. It is diagnosed by a bone mineral density measurement DEXA, dual energy X-ray absorptiometry, at the lumbar spine, at the total hip and the femoral neck. Lumbar spine, total hip and femoral neck. So DEXA or BMD study at lumbar spine, total hip and femoral neck with a T-score less or equal 2.5 by a fragility fracture and a fall from standing height, minimal trauma at hip or vertebra. So one-time screening is recommended in female age more than 65 years. Prophylactic regular weight-bearing exercise and adequate calcium and vitamin D intake throughout the adulthood is a very important. Treatment is bisphosphonate, teriparatide, abaloparatide, SARM, denosumab, and romosozumab, sclerostin inhibitor. It can lead to vertebral compression fracture. So osteoporosis can lead to vertebral compression fracture, acute back pain, loss of height, acute back pain, loss of height, kyphosis, also present with fractures, femoral neck distal radius also causes fracture in the femoral neck, and distal radius Colles fracture. So in osteoporosis, all the labs are normal. Calcium normal, phosphate normal, PTH is normal. If we want to talk about the cause in detail or risk factors in detail regarding osteoporosis, family history, female sex, increasing age, premature menopause, smoking, low body weight with low BMI, which lead to secondary ovarian failure, deficient diet, sedentary deficient diet, sedentary lifestyle, and it can happen in Caucasians and Asians. Mm, type 2 diabetes mellitus, SSRI, PPI, prolonged use, SSRI, PPI, and and long-term SSRI, PPI, and long-term use of heparin, anti-epileptic drug, aromatase, aromatase inhibitors, and glitazone. This is the anti-diabetic drug. These can cause osteoporosis, and prolonged microcavity exposure like space travelers can um, I mean, space traveler can have these osteoporosis disease which predispose endocrine like glucocorticoid excess, Cushing syndrome, steroid therapy, hyperthyroidism, hyperparathyroidism, hypogonadism, Turner's, testosterone deficiency, growth hormone deficiency, diabetes, growth hormone deficiency, diabetes, multiple myeloma, lymphoma, GI problems like inflammatory bowel disease, mm, malabsorption like celiac disease, gastrectomy, liver disease, rheumatoid arthritis, long-term heparin therapy, chronic renal failure, and osteogenesis imperfecta, and homocystinuria. These are the mm, cause. These are the cause of osteoporosis, and there are some research that warfarin may be a risk factor. Long-term phenytoin therapy may have enhanced vitamin D metabolism, leading to osteomalacia rather than osteoporosis. So, long-term phenytoin causing gamma hyperplasia. Phenytoin is an anti-epileptic drug, may cause enhanced vitamin D metabolism, leading to osteomalacia rather than osteoporosis. In the investigation, we can do CBC, urine, REME, routine and microscopy examination, liver function test, ESR, CRP, thyroid function test, follicular stimulating hormone, LH, estrogen, testosterone, and DEXA scan can be done. And the DEXA scan can be done. Osteoporosis, DEXA scan. We actually see the DEXA scan of the femoral neck, total hip, and lumbar spine, femoral neck, and the total hip. These three places is a very important site. Looking for the lumbar spine, total hip, and the femoral neck. These are the three important sites where we see that these DEXAs can dual energy X-ray absorptiometry. T-score based on the bone mass of the young reference population. Young reference population T-score -1 means bone mass of one standard deviation. That of the young reference population, bone mass of one standard below, bone mass of one standard below that of the young reference population, and Z score refer to the bone mineral density compared with that of the normal age age matched, subject adjusted for age, gender and ethnic factors. Age, gender and ethnic factor. T score minus T score greater than -1. T score greater than -1 is normal. -1 to -2.5 is osteoporosis, and more or equal -2.5 is uh, and T score less than 2.5 is osteoporosis. So T score in between T score in between -1 to -2.5 means osteopenia, and if T score is less or equal 2.5, it is osteoporosis. So if we like to say these in such a style, like osteoporosis is a diagnosed according to the World Health Organization WHO and International Osteoporosis Foundation criteria. Normal hip BMD is greater than the lower limit of the normal, which is taken as one standard deviation below the young adult reference when T score 1 or more than -1. Osteopenia is between 1 to 2.5 standard deviation below the young adult reference mean. So T score less than -1 but above minus above -2.5. If T score is below -2.5, if T score is below -2.5, so if T score is -2.7, so it is osteoporosis. Hip BMD 2.5 standard deviation are or more below the adult reference mean in the presence of one or more fragility fracture. So T score minus so T score less or equal -2.5 plus fracture. It is regarded as severe osteoporosis. Osteoporosis glucocorticoid induced. Assessment for treatment: patient taking equivalent of prednisolone 7.5 milligram, 7.5 milligram or more each day for 3 months. So prednisolone 7.5 milligram or more each day for 3 months or longer, and one of the following: over the age of 65 years, over the age of 65 years, and have a history of fragility fracture, and have a T score less than -1.5 standard deviation. The T score less than 2.5 is an indicator of osteoporosis. However, in patients with steroid therapy, T score less than -1.5 is taken as a cutoff. If the patient is on a steroid for more than 3 months, then the T score cutoff is minus 1.5 as a cutoff value. Start osteoporosis therapy and the indication of bisphosphonate and calcium supplementation. Bisphosphonate and calcium supplementation. Treatment of a bisphosphonate, oral bisphosphonate, these should be co-prescribed with calcium and the vitamin D. Oral bisphosphonate should be co-prescribed with calcium and vitamin D. There's a calcium and vitamin D. Patient is on prednisolone more or equal 7.5 for more than 3 months, or with a dexamethasone score less than 1.5 minus 1.5 standard deviation, oral bisphosphonate, calcium supplementation, and vitamin D. Now now the bisphosphonates. If we look at the drugs, if we look at the drugs, if we look at the medications for osteoporosis, bisphosphonate is the number one. Bisphosphonate are the analogues of pyrophosphate, a molecule which decreases demineralization in bone. It causes demineralization in bone. They inhibit osteoclast. So bisphosphonate inhibit osteoclast by reducing recruitment and promoting apoptosis. By reducing recruitment and promoting apoptosis. So it inhibits osteoclast by recruiting, by reducing recruitment and promoting apoptosis, by reducing recruitment and promoting apoptosis. It is the first choice of therapy for osteoporosis. Bisphosphonate inhibit osteoclast. Clinical use, prevention and treatment of osteoporosis. Hypercalcemia. It is a treatment of hypercalcemia, Paget's disease, pain from bone metastasis, pain from bone metastasis. So bisphosphonate is the first line treatment for most patients, taken with water on an empty stomach an hour before food and an hour before food and other medication not recommended for patients with renal impairment. It is not recommended for patients with renal impairment. Atypical fractures are possible with a prolonged use. Atypical fracture possible with oral and parenteral options are available. So bisphosphonate inhibit osteoclast by inhibiting recruitment and promoting apoptosis. So it is used in osteoporosis, hypercalcemia, Paget's disease, pain from bone metastasis, adverse effect, reaction, esophagitis, esophageal ulcer, especially alendronate, osteonecrosis of the jaw, pain in the jaw, and ulceration within the oral cavity, which has persistent for few weeks, increased risk of atypical stress fracture of the femoral shaft in patients mm, taking alendronate. The BNF suggests counseling for patient taking bisphosphonate tablet should be swallowed with plenty of water while sitting or standing, to be on an empty stomach at least 30 minutes before breakfast or another oral medication. Patient should stand or sit upright at least 30 minutes after taking tablet. Guideline for osteoporosis treatment recommend prescription a weekly generic bisphosphonate. Firstly, weekly generic bisphosphonate. Firstly, for patients who fail to tolerate weekly preparation, a monthly oral or more intermittent IV preparation may be thought. So, osteoporosis secondary prevention are under 65 years, require steroid for longer, more than 6 months, and have a T score less than minus 1.5. The initial treatment of choice is bisphosphonate. So patient is on steroid more than 7.5 milligram of prednisolone for more than 3 months, and have a T score less than one minus 1.5 and are under 65. Initial treatment, they should start bisphosphonate. Only if bisphosphonate are not tolerated. Osteoporotic fracture in postmenopausal women. Treatment is indicated following osteoporotic fragility fracture in postmenopausal women who are confirmed to have osteoporosis at score minus 2.5 standard deviation or below. In women aged more than 75 years, a TEXA scan may not be required if the responsible clinician considers it to be clinically inappropriate or unfeasible. A sub, mm, we know that bisphosphonate, you can in bisphosphonate we can start alendronate or risedronate, or we can use etidronate. If the patient cannot tolerate alendronate due to GI problem, we can offer risedronate or etidronate. We can use raloxifene if patient cannot tolerate bisphosphonate. Vitamin D and calcium supplementation should be offered to all women unless the clinician is confident they have adequate calcium intake and vitamin D replete. Treatment criteria for patients not taking alendronate. Okay. The T-score criteria for risedronate or etidronate are less than the others, implying that these are the second-line drugs. Alendronate, if alendronate, risedronate, etidronate cannot be taken, then is strontium ranilate or raloxifene may be given based on a quite strict T-score. The strictest criteria are for denosumab. The strictest criteria are for denosumab. Supplementary notes on treatment. Bisphosphonate, alendronate, risedronate, etidronate are all licensed for prevention of and postmenopausal and glucocorticoid postmenopausal and glucocorticoid induced uh, osteoporosis. All three have been shown to reduce the risk of vertebral and non-vertebral, although vertebral and although alendronate and risedronate may be superior to etidronate in preventing hip fracture. Evandronate is a once monthly oral bisphosphonate. These drugs can cause esophagitis. Now, if we look at the calcitone in this one, it's a modest reduction in the fracture risk, reduces pain from fracture. Calcitonin, exogenous calcitonin inhibit osteoclast activity. Osteoclast activity associated with 1 to 2% increase BMD, which is sustained for up to 5 years. Calcitonin marked decrease in bone turnover and consequently decrease in urinary hydroxyproline excretion, rarely used due to anaphylaxis. So calcitonin can cause anaphylaxis, so it is rarely used. Vitamin D and calcium, poor evidence based to suggest reduced fracture rates in the general population are at risk of osteoporotic fractures and may reduce in frail and household patients. So we can use SARM, selective estrogen receptor modulator, less effective than bisphosphonate, may lower risk of breast cancer. It can cause increased risk of DVT. So raloxifene increases risk of DVT may decrease the risk of breast or endometrium cancer. It may worsen postmenopausal symptoms. The most common adverse effect of raloxifene are hot flashes and leg cramps. Raloxifene does not increase vaginal bleeding or raloxifene does not raise HDL, TG, cholesterol, but may lower IDL. Okay, now strontium ranelate is a dual action bone agent, increases deposition of new bone by osteoblast and reduce the resorption of bone by inhibiting osteoclast. So it causes newborn formation by osteoblast activity and it inhibits the osteoclast. But it has an increased risk of thromboembolic event. Now the denosumab, it risk of infection and skin infection, close monitoring for hypocalcemia needed. More monitoring for hypocalcemia needed. Now, anabolic agent. Before jumping into anabolic agent, let's talk about denosumab, risk of infection, skin reaction, risk of infection, skin reaction. Close monitoring for hypocalcemia is needed for denosumab. Denosumab is indicated in ESRD. EGFR is less than 35 ml per minute. An increased risk of phenosthromboembolism. It's a human monoclonal antibody that inhibits nuclear NF nuclear factor kappa ligand rank ligand inhibitor involved in osteoblast activation, which in turn inhibit the maturation of osteoblast. So they are rank ligand inhibitor involved in osteoclast activation, which in turn inhibit the maturation. So it inhibits the maturation of osteoblast. Rank occurs on the surface of the osteoclast precursors, and osteoclast inhibiting it leads to reduced osteoclast formation and function and survival. This leads to reduced bone resorption in bone, both cortical and trabecular. It is an effective and intermittent bisphosphonate therapy and inhibits pre-osteoclast and osteoblast. Given as a single subcutaneous injection every 6 months. Given as a single subcutaneous injection every 6 months. These near diarrhea are generally considered is two most common side effects. Other less common side effects include hypoglycemia and upper respiratory tract infection, especially used for severe esophagitis and can tolerate daily alendronate. It has 40% reduction in the hip fracture over 3 years. Its side effect is dyspnea, diarrhea, hypocalcemia, upper respiratory tract infection, and atypical femoral fracture. Now, suppose think about a 77-year-old with severe osteoporosis. T-score is 4.2. She has suffered previous Colles fracture, so history of fragility fracture, history of previous left leg DVT. She was unable to tolerate alendronate due to reflux esophagitis. So we cannot give the raloxifene, raloxifene. This group of drugs we cannot give alendronate. The alternative is a 6 monthly denosumab subcutaneous. And we can use teriparatide. Teriparatide. It's a recombinant form of parathyroid hormone. It's a recombinant form of parathyroid hormone. It is a synthetic parathyroid hormone analog. It is given subcutaneous injection and increased osteoblast activity. So it increased osteoblast activity, very effective in reducing bone mineral density, but role in the management of osteoporosis yet to be clearly defined. Hormone replacement therapy, HRT, has been shown to reduce the incidence of vertebral fracture and non-vertebral fracture due to concerns about increased rates of cardiovascular disease and breast cancer. It is no longer recommended for primary and secondary prevention of osteoporosis unless the woman is suffering from vasomotor symptom. Unopposed estrogen therapy is most appropriate if patients have been hysterectomy or oophorectomy and combined hormone replacement therapy is unnecessary. Tibolone, raloxifene, and bisphosphonate are recommended as second-line agent where HRT may be where HRT may be poorly tolerated or contraindicated. HRT may be poorly tolerated or contraindicated. Hip protectors evidence to suggest significantly reduced hip fracture in nursing home patients. Compliance is a problem. Fall of risk assessment should be done in patients with osteoporosis. Suppose a previously fit 47-year-old man comes with a low back pain from a vertebral collapse due to osteoporosis. The most appropriate investigation for this man is testosterone. Osteoporosis in young male would be unusual. On check, you need to check testosterone. So osteoporosis in a young male is abnormal, atypical. So we need to check testosterone. And the drug tamoxifen. It's a SERM, selective estrogen receptor modulator, acts as an estrogen receptor antagonist and partial agonist. It has both estrogen-like activity at sites like bone to increase mineralization, but anti-estrogen-like effect on breast endometrium, preventing breast or endometrial hyperplasia. It, it is used in the management of estrogen receptor positive breast cancer. It is usually taken. It is usually it is usually taken orally once a day for up to 5 years. Removal of tumor, but for patients with metastatic disease, it can continue to be longer. So tamoxifen, once daily drug for up to 5 years. Following removal of the tumor, but for metastatic disease can be used longer. Tamoxifen usually not used in the management of osteoporosis. Raloxifene can be used in the treatment of osteoporosis. Raloxifene is a pure estrogen receptor antagonist and it carries lower risk of endometrial cancer. So this is all about osteoporosis and its risk factor and its medication in detail.